Good afternoon, everyone, and welcome to Friday of New York ACP's Advocacy Week. It is my absolute pleasure to be here today with Dr. James McDonald. Dr. McDonald was appointed Acting Commissioner of Health on January 1st, 2023, and was confirmed by the Senate on June 9th, 2023. Prior to joining the New York State Department of Health on July of 2022, Dr. McDonald served at the Rhode Island Department of Health since 2012. At the Rhode Island Department of Health, he served in multiple roles, including Interim Director of Health, Chief Administrative Officer of the Board of Medical Licensure and Discipline, Medical Director for the COVID unit, as well as Medical Director for the Division of Healthcare Quality and Safety and the Drug Overdose Prevention Program. He was also a member of the Governor's Task Force on Preventing Overdose Deaths. Dr. McDonald has faculty appointment at the University of Albany School of Public Health, as well as Brown School of Public Health. Dr. McDonald earned his MD from Loyola Stritch School of Medicine in Chicago, his pediatric residency in the U.S. Navy, and his preventive medicine residency from the State University of New York. He earned his PhD from the University of North Carolina in Chapel Hill. He earned his BS in biology from Siena College, and he is board certified in pediatrics as well as preventive medicine. His diverse career includes officership in the U.S. Navy, as well as private practice in rural areas where healthcare shortages existed. Dr. McDonald also served in the Indian Health Service in the Navajo region, serving as medical director of outpatient medicine in Chandler, Arizona. Dr. McDonald was awarded the degree Doctor of Humane Letters from Siena College in May of 2024 for exemplary achievement, leadership, and commitment to humanitarian ideals. New York ACP is delighted to welcome Dr. McDonald here today. He will speak with us about the status of immunizations and public health programs in New York State. Knowing Dr. McDonald, he always shares so much more. Dr. McDonald, thank you for being here, and I'm going to turn the program over to you.
Thank you, Loretta. It really is fun to be with you, and good afternoon, everybody. I hope you can see my slides. Loretta, can I just verify you can see my slides right now? Oh, Todd Simon's nodding yes, and same with Hank Chowdhury. And Hank, good to see you again, too. So replacing vicious cycles with virtuous cycles is, really what I want to talk about today. I think we all know what a vicious cycle is. My goodness gracious, if you're a physician, you sometimes know this well, right? But, in other words, there's a problem, but something makes the problem worse. Something else makes it even more challenging, and it just keeps going and going. And the opposite of that, I think we don't talk about nearly as often, is what's the virtuous cycle, which is something good's happen, but how do you make it even better? And how do you make it even better? How do we do things so we make things better? And I thinking a lot more about how do I replace vicious cycles with vicious cycles with virtuous cycles? Because really, I'm in the business of doing good. You are too, right? And I think when you get to thinking about that, I want to just bring you back a little bit, though, historically to the New York State Department of Health's beginning here. We started, on a Tuesday of all days, February 19th, 1901. So 125 years ago, the New York State Department of Health was enacted with legislation signed by then Governor Benjamin Odell. And if you were the health commissioner back in 1901, and really for the first 4 decades, you were struggling with different problems that I'm struggling with today. If you had a patient with diphtheria back then, 1 out of 5 of those little ones passed away. If you had someone with polio, a little one with polio, 1 of 10 out of those little ones passed away. You saw the vicious cycles of that. The virtuous cycles were changed, though. And I'll give you another example. It was another Tuesday, April 12th of 1955. It was at the University of Michigan School of Public Health in Ann Arbor where, then Dr. Thomas Francis announced that the Salk vaccine was over 90% effective. And I don't know if you can imagine what that was like, but if you're from New York State where you knew a governor who was confined to a wheelchair from polio, that was pretty amazing news. It's funny, that press conference, there's a video out there of it. It's in black and white on YouTube somewhere. But it's really one of those things where it was chaotic. People were so excited, and the world was just an amazing place. And to share a little more about New York State Department of Health, we used to operate the Reconstruction Hospital for Children in West Haverstraw, New York. It started in 1901. It took care of children with polio. Now it's known as Helen Hayes Hospital. It's a rehabilitation hospital. New York State Department of Health used to operate 7 tuberculosis hospitals. We don't operate any anymore because that's not how you take care of TB. We have that under control, and it really underscores there's so much we do in public health that really solves problems. And I'm hoping that we can share a little more of that today. And I want to share a little bit about Governor Hochul's priorities too. And some of this was just announced yesterday in the budget. But you might wonder, why does the health commissioner care about universal child care? Well, it's one of the biggest expenses for people. When young families can have a chance to actually save some of that money and spend on more virtuous things like rent and food and clothing for the kids, an occasional Christmas present, that just makes everything better. And the governor is really concerned about social media in children. I am too. I'm very worried about the dangerous social media algorithms that really do affect children. I'm concerned about artificial intelligence as well that target minors. So there's work going on in New York that we're getting some nice consensus on to help that as well. Of course, the governor is very interested in protecting our communities, right? Doubling down on proven crime fighting strategies, continuing to get illegal guns off of our streets, very important as well. And of course, addressing the immigration issues as well, right? Like, in other words, very concerned about just making sure that people can live their lives in New York State, go to church, wherever you worship, hospital, healthcare, and, just all kinds of places like school, and not be concerned about whether or not Immigration Customs Enforcement is coming to, quite frankly, take you from that. So there's a lot of things that the governor aligns with that I think really change vicious cycles and move them into virtuous cycles. And I want to just start a little bit too, talking a little bit about money. I know it's sort of odd to bring money into a continuing medical education talk, but it's important to understand how we get the money we get, right? When you think about money, New York State has a pretty large budget. This is the proposed budget. I haven't seen the final number yet for this year's budget, but it's supposed to be $262.7 billion is what we proposed. The Department of Health would have $113.8 billion, and $101.8 billion of that really goes towards Medicaid and the Essential Plan. In other words, direct patient care, which a lot of you benefit from. Quite frankly, we're happy that we can do that. We like insuring people, right? And speaking of that, I want to just talk a little bit about health insurance because there's a lot of that going on in the news, right? I'm concerned about what might happen to Medicaid because of H.R. 1. And I want to make sure folks know we're taking a very serious approach about this, being very vigilant. We have 6.5 million Medicaid enrollees in New York, 1.7 Essential Plan enrollees. Essential Plan is a product of the Affordable Care Act. And so we insure a lot of people. We are the largest payer in the state. And in April of 2024, I was more than a little excited that we were able to expand the Essential Plan to people 200% to 250% federal poverty. And just to give you a little context on that number, because I don't know how many people keep track of the federal poverty level in their mind, but if you're someone who works in upstate New York and you work for minimum wage, that's $16 an hour. If you work 40 hours a week, 2,080 hours a year, full-time job, working every day, you're going to make $33,280. You were in that group of 200 to 250% federal poverty level if you were a person who lived alone. This is the group of people that, quite frankly, H.R. 1 decided we couldn't insure anymore. So it concerns me with the posture they took with that. Having said that, we did make some changes here to help people stay insured as much as possible here. And I want to give you a little bit of what we're doing in this regard. The timeline is this July, coming up just really in a couple months, the folks in that 250% federal poverty level are going to revert back to what's called the 1331 Basic Health Program. So those individuals, we think it's about 450,000, are either going to have to get employer-sponsored health insurance, which probably is going to come with some contribution on their part, or they're going to choose to get something as called a qualified health plan, which they may or may not be able to afford. I'm concerned about that. In August, we have to start sending out initial work requirement notices. And I'll talk a little bit more on what we're doing to get ready for the Medicaid work requirement notices. In October, people who are, there's going to be some challenges for people we have to look into for immigrant eligibility, the restrictions in Medicaid that affect New York uniquely. And then in November and December, we are going to be preparing for the 2027 expansion policy changes. In other words, some of the changes in HR 1 for Medicaid is it's a shorter enrollment period. It used to be 12 months, now it's 6 months. There's work requirements. There's exceptions to that, but I'll go through that in a minute. Redetermination every 6 months instead of every 12 months. And there's going to be some legacy system migration. We have our work cut out for us, and we know that. And in January, the work and community engagement requirements begin. So that's going to happen then. And just to put a little context around the work and community engagement requirements, keep in mind the Medicaid, this only applies to the Medicaid expansion population. These are adults 19 to 64 who do not meet exceptions in 80 hours of qualifying activities monthly. So you have to be in a work program, or you could do some community service, and you can do an education program at least half time. And the income requirement, keep in mind, is based on the federal minimum wage of $7.25 an hour. So you only have to show you've made $580 a month in order to do that. So, there are about 20 states who still, that's minimum wage, which is really very little money here. And then there's a look back period that we have to keep in track of as well. And there's, steps for seasonal workers can be assessed on the previous 6-month average income to determine if they meet the income requirements. The main point I'm making here is it's going to be a lot more complicated, but we're working through that to try to keep people covered who need to be covered, And I did talk a little about the exemptions. Now, keep in mind there's 14 different exemptions. Now, I'm not going to read through all 14. You can look at that while we're talking here. But, 18 years old or younger will be exempt. 65 years or older will be exempt. Anyone who's pregnant, anyone enrolled in Medicaid due to a disability. And my point is, some of this information we can pull out electronically. Some of this information we can verify. So it really is going to narrow the population of individuals that we have to keep track of here. And, I do want to talk a little bit about how we're going to look at the data here. We're being very intentional about this. One is we're looking at some federal data sources we have access to, and they know that. We have state agency and data as well as, external data that we can access as well. We're going to be getting internal data as well, and we're doing third-party solutions. I don't want to get into what third-party solutions we're going to do because that's in the procurement period right now. But in other words, there's a vendor that we're going to do that will integrate with the New York State of Health. And with the vendor integrating to New York State of Health, it should be a lot easier for people who have to verify their income to just simply upload the document they need to so we can verify that. What we're trying to do is very intentionally make this user-friendly. What we're trying to do is make sure people who need Medicaid can stay on Medicaid and really help everybody with that regard. Having said that, there's going to be a different direction here. But you see, health insurance creates virtuous cycles, doesn't it? Like when you have health insurance, you can access health care. You can get better quality health care. You really can look for better outcomes. If you don't have health insurance, then it's really harder to access health care. It's harder to get the quality outcomes. And if you do find health care problems, sometimes it's when it's very late in the stage of the disease that creates a vicious cycle. So we're really trying to address these things. And, one of the things I thought I would just put on the table in front of you today is, the federal government and the New York State Department of Health, we're really heading in different directions. I would say it's a bit of a contrast the way we look at delivering health policy and the way they're looking at health policy. And I wanted to bring this little slide into the conversation just to help you see this a little bit. Like, we did the 1115 Amendment, the New York Health Equity Reform. We thought that was important to help create social care networks, to help safety net hospitals, really to do some other things to improve workforce. We did the Master Plan for Aging about a year ago, June of 25, so people could age in place in New York State. Last summer, we released our 5-year state health improvement plan called the Prevention Agenda. We provide and promote access to vaccines. We talk about the evidence and the science. We support the prevention of dental cavities with community water fluoridation, and we're improving the healthcare workforce. I'll talk a lot more about that later. When you saw the federal government, though, you see cuts to National Institute of Health. I'm concerned about the impacts that's going to have on medical breakthroughs. You saw cuts to Centers for Disease Control and Prevention. Health Resources and Service Administrations had cuts. Substance Abuses and Mental Health Service Administrations have cuts. They're doing efforts to roll back fluoride use. There's just overt opposition and confusion about vaccines. And I have to say, I'm not opposed to removing synthetic dyes. I think that's okay. I mean, I just want to make sure we know this among friends, though. There's no such thing as a healthy Dorito. So, as much as I applaud the work, it's not going to change the universe, is it? And Tylenol and autism, they put out a statement on that was quite frankly just irresponsible. I don't know how else to describe it. I released a public statement on that, but you really just saw they were really just didn't approach that in a way that made any sense. It was not borne out by the peer-reviewed literature here. I do want to chat a little bit though about. You asked me to talk a lot about immunizations, and I'm going to talk a lot about immunizations, but it's hard to talk about immunizations without at least acknowledging the word infodemic, right? And it's a term that I think the World Health Organization has talked a lot about as well. But we are in a time where there's an overabundance of information, some accurate and some, quite frankly, not. And really what you see is there's a nice little graphic we took from them that just sort of illustrates what happens. And really one of the things that you ask is, did you double check your facts? And my goodness, if you're seeing patients and you're in the exam room, you're dealing with this every day. I hope you've kept your patience about dealing with your patients, and I hope you've kept your kindness and compassion. But it can be a little bit challenging. I have to admit, when most of us were in our training, this wasn't as problematic as it is now, and it seems like it's only getting more and more concerning what people come in with. What I try to do is make sure that my Department of Health just really puts out honest, objective information. I try to stay above the fray as far as responding to every little thing the federal government says, and more so just focus on putting out honest, objective information that people can take hold of and advise for their lives. I think you saw what happened to the Advisory Committee on Immunization Practices. Quite frankly, I put a statement out March 16th addressing what the court said about that. I thought it was encouraging to see the court acknowledge the flaws in the hastily formed Advisory Committee on Immunization Practices and their lack of expertise in vaccines. To me, the New York State Department of Health is a credible source of information on vaccines. We have a vested interest in keeping our population healthy. That's really our only vested interest. And one of the things I think if you give vaccines as part of your profession, I think healthcare providers don't give vaccines to make money. Far from it. Providers give vaccines because we know it's the right thing to do. But the conflicting information from the federal government on vaccines is creating more confusion, and it just isn't helpful to have to combat this on a daily basis. And I think it's important to understand how we look at global threats in this context as well. It's part of the conversation about how the federal government went a different direction than the New York State Department of Health did. The federal government chose to exit the World Health Organization. We chose to join the World Health Organization's Global Outbreak Alert and Response Network, which is interesting. It's helping us right now as we're dealing with the ND strain of the hantavirus. More information for us. Quite frankly, it's helpful. We're in the public health, profession for a reason. We like to get the best information, get it quickly, and disseminate it as widely as possible. And to me, the World Health Organization, working with the CDC, working with state health departments and local health departments is still a good thing. More and more, just so people know this, about a year ago, we started putting, actually it's about a year and a half ago now that I think about it, the Global Health Update. If you're interested in this, every Friday at noon, it just came out 22 minutes ago for those who are curious, we put out a Global Health Update on what are the different things going around in all different parts of the world. What are the emerging infectious diseases? There's the QR code to it, but you just simply go to globalhealthreports.health.ny.gov. This is something we're doing. We started doing it about a year and a half ago, and I thought was, we don't know that you're hearing what you need to hear about what's going on in the world. We feel like it's better for you to know. We track everything from chikungunya to hantavirus right now. And now I want to talk now a little bit more about immunizations, which really was one of the main things you wanted to talk about today. I think measles is really the first topic we're talking about, and I'm a little bit sad to even talk about it. I think most of us were around when it was declared eliminated in the year 2000, and yet we're seeing the opposite right now, just how it's increasing not just nationally but internationally. And in case you're curious, in New York State, most of our cases are coming from outside New York State. In 2025, we had 48 cases of measles. And that concerns me. Right now, so far this year, we have 10 so far in the entire state. The majority of these are coming from outside of the state. Sometimes they come from other countries. Sometimes they come from other states. But if you're wondering why measles outbreaks have not really taken off like they did in 2019 in New York, part of it's because local health departments, state health departments work quickly to contain the case. We identify the case, we do the contact tracing, we also offer post-exposure prophylaxis really right away if it's indicated. But part of the reason is our immunization rates in New York aren't that bad. I'd like to see them higher. We're about 81% for people under age 2, but closer to 97%, a little over that, when people are entering school. So that's what helps us. And the reason why we're doing so well is New York State is one of the few states that does not allow a religious exemption for immunization for school entry. And that's really one of the things that helps us keep our immunization rates that high. And I think that's really important. It saddens me that a vaccine that's been around since 1963 for the measles vaccine, 1971 for the measles, mumps, rubella vaccine. In other words, that MMR we're giving has been around for 55 years. Is really still challenged so much as it is. I've personally given, I don't know how many thousands and thousands of doses, still waiting for my first problem from one of those. I'm trying to talk a little bit about influenza rates in New York State. We just got done with this flu season. I just declared it no longer prevalent about 2 weeks ago in New York State. But what do you think is flu seasons have gotten increasingly severe? And it's interesting, in the public health world, we have this saying, if you've seen one flu season, you've seen one flu season. But if I look at the last 3, I can't help but notice they're getting more and more significant. This year's, wow, what a steep incline. We had a historic week with the number of people admitted to the hospitals for flu this year. And our immunization rates, well, they were okay, but they're really not what they're supposed to be. And I think this is just part of the world we're living in, where we're seeing slower and slower declines in flu vaccine. And, of course, the flu vaccine isn't the best vaccine we have, but it's the best tool we have. But what we're seeing is when you look at different populations of individuals, you're seeing flu vaccine is gradually declining, and it wasn't that great to begin with. I think one of the things I find when I'm in the exam room is people don't always listen to me anymore. In other words, they had their mind made up before they came in to see me, which concerns me. In other words, you trust me with your child's health care, but you got your information from somebody before you walk in the room. And I kind of miss the days when people had a question, just said, well, can I ask you about it? As opposed to, would you like the flu vaccine? And you get absolutely not. I don't think that's the answer that's helpful, because we didn't even talk about it. And so it concerns me that that's where people are getting their information from sources that, quite frankly, I don't think are nearly as trustworthy. And I want to show a little bit of data about flu in New York State. One of the things I think it's important is just to remember that people do pass away from the flu, and this is our pediatric data. And I thought you would find this. Now, this is the 25-26 flu season. 16 pediatric deaths, which concerns me. 4 were vaccinated, 11 were unvaccinated, 1 was ineligible for vaccination. And I think it's just important to know that's kind of what you see for most years when you're seeing our pediatric deaths. What you see is that the people who are getting, quite frankly, passing away aren't generally vaccinated. If you look at 2024-25, we had 27 deaths. That was a lot for last year. Would it concern me how many we have? Now, keep in mind, New York State, a flu death is reportable. That is not the case in every state. So we know when there's a death. Having said that, other states may not be getting that information like we are. But when you look at 24-25 in particular, it's really hard to see. A lot of little ones were ineligible for the vaccine, too young. And then you look at that data, the big orange part there, like, wow, little ones just weren't vaccinated. That's just hard. And I think it's important to know that this is just concerning to me, Of course, it was quite a year for respiratory syncytial virus. Now, we started making RSV reportable. We just started that a couple of years ago, but we, have put a standing order together. I was able to sign a standing order to increase access to the RSV vaccine. I can tell you as a pediatrician of 36 years, delighted that there's an RSV vaccine. Absolutely delighted. I can't tell you how it feels as a pediatrician to not be able to do what you want to do for little ones who are suffering. So really delighted to see a vaccine for that. But we really saw a very long season this year. A lot of cases, a lot of hospitalizations. And the vaccine uptake is what it is. It's heading in an interesting direction here. But there's one now for infants, one for people who are pregnant, and one for people like me who are, quite frankly, old enough to get it. And it's only a one-and-done vaccine for me, which I'm pretty happy about. I want to put some data about COVID-19 and flu, hospitalization and deaths for you here. I know it's troubling and talk about the pandemic. It's still fresh in my mind as well, my friends. But I do think we need to keep it in mind here. Like, it is still significant. You know, we're seeing less and less hospitalizations every year. I just put the last 2 years here for you to look at. But it is interesting. I think that there's generally a little bit of confusion among our patients about this information. The thing about COVID is it really hasn't picked a season yet. It's really available year round with COVID. So when you look at that number, you know, of deaths there of 1,320 for, quite frankly, 24, 25, and 572 October 25 to present, it's a sobering number when it comes to deaths. When you look at our flu deaths, it's 768 for the comparable time period of 2024 2025. And my point being is we're still seeing more deaths from COVID vaccine than we are from flu. But what you're not really seeing is uptake of COVID vaccine. I think what we're seeing is maybe 12, 13% of the population is getting the COVID vaccine. Just certainly not where we need it to be. And, you know, I'm concerned, too, that we didn't get the information from CDC this year about COVID vaccine. I understand they had some questions about the methodology at senior leadership at CDC, but it seems to me that if you had gone with the methodology you've used in the past, we at least could have compared apples to apples in that regard. Vaccine confidence is something near and dear to us, and I just thought it'd be important to put a little definition out there so people knew what it was. But you're really seeing a national loss of vaccine confidence. You know, some of this comes from loss of trust in Centers for Disease Control and Prevention on vaccine information. That's at the lowest point following recent changes to the recommended childhood vaccine schedule that was just done without any real academic rigor, and there was really no new information. That was just based on people's long-held biases. Half the public has heard about the changes in the federal childhood vaccine schedule. Among those, more say they expect the changes will hurt children more than help. Fewer than half of adults say they trust the agency at least a fair amount. So I think you're really seeing CDC is really going through some challenging times. In case you're curious, when I talk to colleagues at CDC, I always thank them for staying and encourage them to just do the best they can during these challenging times for them. Because we still need them, you know, and I still rely on them, and I still consider the people who are legacy CDC members to be a strong partner and a trusted resource for me. There's a lot of causes for vaccine hesitancy: distrust in institutions, growing skepticism towards healthcare systems. Of course, culture and religious beliefs are always a challenge, and they can be self-reinforcing with little contact with the medical field. There's no shortage of misinformation and myths, and there is legitimate concern about side effects. I welcome those questions in the exam room. I'm happy to talk about those. Happy to talk about anything, really, quite frankly, and I create space in the exam room for those questions. You know, I was never trained to get into conflict in the exam room. I was always trained to be empathetic and compassionate, and that's what I do. Like, I choose not to argue with my patients. I just don't. I don't find it's ever helpful, because the exam room is a place for healing, not a place for conflict. There's a lot we're doing to increase vaccine confidence, by the way. You know, we have a lot of this addressed in our State Health Improvement Plan, working with local health departments. You know, we're supporting the National Human Papillomavirus Roundtable Start at 9 campaign. We're working on vaccine preventable disease prevention and control. We've development of the Health Ambassador Community Health Workers for Immunizations program. We're working with local health departments to reach groups that are hesitant. And, you know, we do a lot of fact-based and encouraging information on vaccines through press releases, interviews, podcasts, social media, public service announcements, videos. Even did a paid commercial campaign last year. We do support legislation. I'm excited to see some of the stuff that the legislature's been really a strong partner on with the governor this year. That's been really helpful. And we do collaborate with anyone who will collaborate with us, too. And I think it's really important to know that healthcare provider strategies do increase vaccine confidence. You know, we know patients trust you. We know patients want to hear from you. And we actually have billing codes to help you get reimbursed for this. And I wish they were used more than they are. And I thought it'd be helpful just to put these Medicaid fee-for-service codes out there for you and how much we're currently paying. You know, if you use the 99401 code, we'll give you $12.63. The 90482, immunization, counseling, vaccine not given. In other words, we'll pay you for that too. Now, you might think, like, why is it so much more? You didn't give the vaccine. Well, part of that's because we know how much time you spent in that. But, you know, in other words, we're trying, folks. We are really trying to give you money to do the vaccine conversation. And we are trying our best to help you have the best information out there. Vaccine confidence does vary by vaccine. If you're seeing patients, you've noticed that as well. But I thought this graph was kind of interesting. Confidence in long-standing childhood vaccines like the measles, mumps, rubella vaccine, polio, is higher than confidence in, newer vaccines like COVID or even the flu vaccine. But confidence overall has been declining. And if you look at this, like the burgundy being somewhat important, lighter color, very important, somewhat important, not too important, not at all important for measles and mumps and rubella. Like 9 in 10 parents say it's important for children to be vaccinated against measles, mumps and rubella, and polio. Fewer say the same about flu and COVID, which I think just speaks to a little bit of the cognitive dissonance sometimes I see in our patients, which is as important as it is to get your MMR vaccine. I still think it's important people to look at the other vaccines for flu and COVID because you do see significant morbidity and mortality. We do a lot with cervical cancer prevention. It's tragic when someone gets cervical cancer. Humble opinion, I think this is a cancer that could be eliminated. As early as age 9, it's just 2 doses. It used to be 3, but it's great to see that we have this tool for people. But you see a lot of, just quite frankly, confusion among people about the cervical cancer vaccine. It's most commonly sold as Gardasil, the brand name. But it really does a wonderful job preventing 90% of human papillomas-related cancers. And we continue to recommend the hepatitis B vaccine, quite frankly, the birth dose. You saw some direction from the federal government that just quite frankly we thought was just ill-advised and poorly researched and just missed the public health argument completely. One of the things about hepatitis B vaccine, I was around when that came out. I am that old, my friends. But I remember it being the first vaccine to really prevent cancer, because if you prevent hepatitis B, you do a lot to prevent liver cancer. And then, of course, we have a division of vaccine excellence. And we really transitioned from reacting and responding to planning and adapting. We created the division of vaccine excellence early in my time here in 23, just to really get ahead of this issue and try to really put more strategies towards purposely being intentional as the New York State Department of Health about what we can do to make sure people understand what vaccines are, how they work, but just keep the health equity perspective in mind here. We really want to stop these vicious cycles. And, one of the things that I'm just lamenting a little bit about is how the federal government went towards hepatitis B vaccine. Nothing changed in New York State in this space. But the thing about this is, you give the vaccine as a baby, you do want to know hepatitis B status, but we don't want to miss a baby getting hepatitis B. The data on that is pretty clear. 90% of the little ones with hepatitis B who aren't given the hepatitis B immune globulin in the hepatitis B vaccine will go on to become carriers. And that's tough, because then you have a little one with an untreatable disease for the most part. That's so easily preventable. So really sharp disagreement with the federal government on the recommendation with that regard as well. The governor's been extremely supportive of everything I've done. I just really can't thank her enough for being such a champion of science and public health. She really is a delight to work with. I was thrilled to see this pass the Assembly and the Senate. I believe it passed last week. I expect it to be signed shortly. But it's going to allow the Commissioner of Health, in this case me, in consultation with recognized medical organizations, to establish immunization requirements that guide school eligibility. So in other words, not relying anymore on the advisory committee and immunization practices, but relying on subject matter experts. But regrettably, that's the path we've chosen as a country, but we in New York State are choosing a path that, quite frankly, follows the science and moves forward in giving greater clarity to our healthcare providers. I'm going to shift my conversation and talk about another subject that's a vicious cycle, which is workforce. One of the things that concerns me about workforce, if you think about it, if you have a shortage of healthcare workers, you limit access to care. So you see the vicious cycle starting, right? Shortage of healthcare workers, less access to care, less quality outcomes, more stress on healthcare workers who are working, more burnout. You see more complaints in the regulatory space. You see more workplace violence. There's no benefit to having a shortage of healthcare workers. You see undue pressure on Medicaid. It just really becomes problematic. And what I'd rather see is a virtuous cycle where we have an abundant supply of healthcare workers, so we have great access to care, better opportunity for quality outcomes, less workplace stress for healthcare workers, less workforce violence, less pressure on Medicaid, and just so we can all have a breath here. So right now, we have committed $570 million to improve the healthcare workforce in New York State. This money goes until March 31st of 2027. That doesn't include anything we get in this budget. It's money through loan repayment programs, workforce training and development, and building the workforce pipeline. And just in case you're someone who was curious, we have 25 different programs. And this surprised me this year when I added it all up. I just kept noticing we had all these programs. And I just said to my team, lay it all off me. And I have 25 different workforce programs with different layers of funding in it. And the one I want to draw your attention, right in the middle there, it says the Career Pathways Training Program. That's through the 1115 Amendment. That goes to March 31st of 2027. Now, the Career Pathways Training Program is helping me find people, high school, college, whatever it takes, to get them interested in healthcare through their healthcare education. We have other investments, the Area Health Education Center, the Associated Medical Schools of New York, Schools of Medicine and Science. Like, that money is actually trying to diversify our healthcare workforce, and we know we need to diversify our healthcare workforce. We know there's a population that is underrepresented in medicine. That helps nobody. And we do to diversify the workforce. We have money invested in that as well. We're doing a lot just to improve the number of people who even work in home care, recognizing that's an important area as well. Part of what I'm trying to get at is we have a lot of healthcare workforce programs. We're trying our best to make a generational investment to improve the healthcare workforce. I'm not going to go through all of this, but I just thought it'd be important for you to see this is a really comprehensive approach, and I'm really hoping we have a shot at just really changing healthcare workforce in New York State. Just to bring another concept in the room, you can't just talk about workforce. You got to talk about scope of practice, right? In other words, New York is different than other states, and we have to sort of say sometimes the difference is great, sometimes the difference is not so great. But, when I go to nursing homes, they're telling me we wish certified medication aides could give basic medications in nursing homes like they can do in 38 other states. We wish medical assistants, I hear this from practices, hospitals, federally qualified health centers, we're the only state where a medical assistant can't give a vaccine. I need to say that again, my friends. We're the only state where a medical assistant can't give a vaccine. I think this is one of those things where if you're concerned about this, please let your membership in the Assembly in particular know. The Senate supported this last year. The Assembly had some real support in it, but it just didn't get over the finish line. But I think this one's really important. We have a nursing shortage. Only half the nurses who have a license are actually in direct patient care. So let me say that one more time. Only half the nurses who have a license are in direct patient care. That's for a lot of reasons, not the least of which is a nursing degree is a great degree. You can do a lot of things with a nursing degree. So I'm not saying there's anything wrong with that. What I'm saying is we have a shortage of nurses. Now, we're doing a lot of investment. We are. But we have to be honest about this among friends is anybody who's a medical assistant who's appropriately supervised and trained can give a vaccine. You have a shortage of nurses. There's too many places employing a nurse just simply to give a vaccine, and that does limit vaccine access in places here too. I have so many pediatricians tell me they just can't hire a nurse because of the nursing shortage, and they get paid so much more working in hospitals. So it's a concern. The last topic I want to bring to your attention is food security. You might wonder, why does the state health commissioner care about food? Well, food's a social determinant of health, and we have some data on food in New York that concerns me. No child in New York should go hungry, or families should have enough access to healthy food. But when you look at food security, and food security means where the next meal is coming from. You're confident about that, right? So 72% statewide, based on our behavioral risk factor surveillance system data, are food secure. So 72% are food secure. Now, the darker shading represents lower food security and higher need. So when you look across New York State, you see way too many counties have that darker shade to them, which concerns me. We know when people don't have food security, it creates vicious cycles. They eat whatever they can when they can, and they don't have access to healthful foods, which creates more chronic disease. You just see the vicious cycle getting worse and worse. When you have obesity, it leads to so many different chronic diseases, whether it's heart disease, kidney disease, whether it's a joint disease. You just see obesity leads to so many other chronic diseases. 28% of emergency food recipients are children. That concerns me. Almost 35% of residents have incomes at or below the 200% of federal poverty level in New York State. That concerns me as well. New York is a state where there's a lot of income disparity. I think you know that. 12% of New Yorkers do not always have enough money to meet their basic nutritional needs, according to the United States Department of Agriculture, which is why the governor is so focused on really improving affordability in New York State and really making food more plentiful. And so I think the next question is, well, what do we do about food in New York State? What specifically does the health department do? So interestingly enough, I have over $1 billion annually to fight hunger and improve nutrition in just the New York State Department of Health. And I think that number might surprise some people, but the Hunger Prevention Nutrition Assistance Program, $110 million to fund our food banks and food pantries across New York. Nourish New York, I do with Ag and Markets. It's almost $47 million. Nourish New York is New York grown food, and we help supply food banks with that. We have the Common Commodity Supplemental Food Program, the Child and Adult Care Food Program, $257 million. I have the Special Supplemental Program for Women, Infants, and Children, $614 million. The WIC is a really important program. When you think about WIC, Women, Infants, and Children, that's not designed to be all the food you need, but it's designed to be most of the food you need. So people often qualify for WIC and SNAP. I'll talk about SNAP in a second. Medicaid covers some infant formula. I spend almost $18 million a year on that. I have the Ryan White Service Initiative, $3 million. People are HIV positive to help with food. Medically tailored meals through Medicaid's $2.6 million. I have value-based payments I do as well. And I have health-related social needs, Social Care Network's 1115 waiver at $3.4 million. We are not the only state agency, though, that invests in food. I have over $1 billion committed to address food, but other state agencies do food as well, right? So the New York State Education Department, that universal school breakfast and school lunch the governor championed last year, that's a wonderful program that the governor did, and it's great to see that working. The New York State Office of Temporary and Disability Assistance does a supplemental nutrition assistance program. That's $7.5 billion a year, and they do more than that. The New York State Office for Aging has food programs, and the New York State Department of Ag and Markets does food as well. Part of what I'm getting at is there's a lot we do in New York to address food because we know food is really important. And this is just a little illustration about what the New York State Office for the Aging Nutrition Program is. Since its inception in '75, it's really helped quite a few older adults, almost 22 million meals. Largest nutrition program for older adults in the United States, which is something we can be really proud of. All right, I'm getting closer to the end because I really wanted to leave a lot of time for questions, because when folks reached out, they really wanted to have time for questions, and I like asking questions. It's a chance for me to learn what's going on. But this last slide I want to just mention a little bit about real quick is New York State did lead the founding of something called the Northeast Public Health Collaborative. It's a partnership of different jurisdictions, states and territories, and major cities from Maine to Virginia, representing over 80 million Americans. It's not political. In fact, it's an apolitical force multiplier working together to advance, health equity. That's all we're trying to do here. It's really one of those things where we should have done this decades ago. We just work together as all these different jurisdictions sharing information. You'll see there's 7 different work groups we have working on, from preparedness all the way to maternal health there. And it's been nice to see some of the things we've been able to do here. And I think what you see now is more and more health departments across the country working together. The Northeast Public Health Collaborative, it's really now 18 different jurisdictions doing this together. And it's been a very positive experience for us. We've gotten a little bit of funding from some partners to actually support this. And we're hoping to get some more funding as well in the future. And I want to end with this slide on purpose, really. As I think about our mission here, protect and promote the health and well-being for all, building on a foundation of health equity. I started my talk talking about vicious cycles, replace them with virtuous cycles. What I'm trying to do is replace every vicious cycle I can find, my friend, with a virtuous cycle. And I hope you share in that mission as well. When I think about so much of why I went into healthcare, which is probably the reason you went into healthcare, is I really just want to help people, want to relieve suffering, and just want to really, quite frankly, do good. It's a lot of why I'm in public health as well, and it's really what helps me sleep well at night and wake up in the morning with a little bit of verve and panache to get ready for the day.